Back pain. It feels like one of the most common things that can go wrong with the human body. And the advice you get can be, well, it's all over the map. Today, we're going to cut through all that noise. We are going to walk through the actual evidence, step by step, and build a really clear roadmap for what to do when your back decides to quit on you. Let's get right into it.
I mean, just look at that number. Nearly 80%. It's practically a universal experience. If you haven't felt it yet, chances are you will. And when that sharp, sudden pain hits, the real question isn't just, why is this happening? It's, okay, what do I do now? And as we're about to see, the answer really depends on what's going on under the hood.
So, let's start at the very beginning. That first awful moment, that ouch. Understanding this initial acute phase of back pain is absolutely the most critical step to getting on the right path to recovery.
Okay, first things first, back pain is not one single thing. Your journey basically splits onto two main paths right from the get-go. On one side, you've got what doctors call non-specific acute low back pain. This is the big one. We're talking a staggering 90% of all cases, and it usually gets better within a month. On the other path, there's a more specific problem, a lumbar disc herniation. That's where a disc in your spine is actually pushing on a nerve. Your entire game plan starts with figuring out which of these two roads you're on.
So for that huge majority, that 90% of people with that general acute pain, the good news is there's a very clear evidence-based playbook. The World Federation of Neurosurgical Societies has laid out this stepladder approach that's actually surprisingly simple, and it works.
And here's that playbook. It's called the stepladder approach. And notice where it starts. Step 1 isn't some powerful drug, it's just understanding what's going on and modifying your activity. And notice I said modifying, not stopping. From there, you can climb to the next step. First-line meds like NSAIDs, think ibuprofen or acetaminophen. Then, and only if muscle spasms are a real problem, you might consider a muscle relaxant. The whole philosophy here is to start low and go slow.
This brings us to one of the biggest flip-flops in modern medical advice. For decades, the go-to advice was go lie down in bed. But we now know with overwhelming evidence that lying still for more than a day or two is one of the worst things you can do. It actually makes you stiffer, your muscles get weaker, and it slows down your recovery. The mantra now is motion is lotion. You gotta keep moving, gently, it's key.
But what if you're not in that 90%? What happens if the pain just hangs on? Especially if you've got that sharp shooting pain going down your leg. Well, now we're heading down that other path, toward a possible diagnosis of a lumbar disc herniation.
Before we go any further down that road, I want you to just look at this number, 66%. According to a huge scientific review, that's the percentage of herniated discs that the body just reabsorbs on its own with time and conservative treatment. Your body has this incredible ability to heal this problem without a surgeon ever getting involved. So the big takeaway here is time and conservative care are seriously powerful. Now, while we just said time is your friend, there are some major exceptions. These are the red flags. Symptoms like cauda equina syndrome, which can involve things like losing control of your bladder or bowels, or if you notice a weakness in your leg that's getting worse and worse. These are not wait-and-see situations. These are medical emergencies. They mean you need to get checked out right away. Okay, so assuming none of those red flags are flying, the journey for a disc herniation still begins on the conservative path. Surgery is not the first stop on the train. The whole goal is to give your body that chance to do its thing and heal itself, using a whole toolkit of non-surgical options first.
And this is what's inside that conservative toolkit. It's really a multi-pronged attack. You've got activity modification again, you've got NSAIDs to help with that specific nerve pain or sciatica, there's targeted physical therapy, and sometimes even epidural steroid injections to get medicine right to the inflamed spot. The idea is to use a combination of these to manage your symptoms and just buy your body the time it needs to heal.
This timeline is so key to understanding the modern approach. For about 6 weeks, you give that conservative treatment a real, honest shot. Now, that 6-week mark isn't some magic deadline, but it's a very well-established crossroads. It's the point where, if you're still in a lot of pain and can't function, you and your doctor start to have a serious conversation about what the next option looks like.
So let's talk about that option. It's really important to frame this the right way. Surgery is not a punishment. It's not what happens when conservative care fails. It's a highly effective tool that's just reserved for the right patient at the right time.
This chart, which is based on a landmark study called the SPORT trial, lays out the central trade-off perfectly. Just look at the columns. The biggest, clearest advantage of surgery is the speed of relief. It's faster. But now look at the long-term outcomes. After a year or even longer, the results for people who had surgery can look very similar to those who stuck it out with conservative care. So a lot of the time, what you're really doing is trading the risks of surgery for faster, more predictable relief from severe pain.
And for anyone thinking about surgery, this is a really fascinating point. The evidence is solid that surgery itself can be a big help. But what the evidence is not clear on is whether one specific technique, like a big open surgery versus a minimally invasive one, is definitely better than another when it comes to the final outcome.
So when you put all of this evidence together, it doesn't point to one single flashing neon sign that says this is the right answer. Instead, it points to something way more important: shared decision-making. The evidence gives you and your doctor a map of the territory, but you decide together which path to take and when.
Ultimately, this whole explainer is about giving you the what. What are the options? What are the timelines? What are the trade-offs? But the when to keep pushing with physical therapy, when to think about an injection, when to start the conversation about surgery, that is a personal decision. It's guided by your symptoms, your goals, and a good conversation with your doctor. The whole point is to make sure that conversation is an informed one. Thanks for tuning in.